Good morning, everybody. Thank you for being here this morning on this once again snowy morning. I was going to sort of put out some flamingos and palm trees and whatever and kind of get people in the mood, but I figured people are enjoying another snowy day. But thank you. So we begin as we always do, talking a little bit about where we are, where we've been. The good news is one of the things that I think this group has done in collaboration with all of our stakeholders a really good job about addressing was that uptick that we had seen last year, pretty substantial uptick in the use of opioids in situations where people had died by suicide. And keeping in mind that when we would call something a death by suicide, the bar was very, very high. So it was absolutely, there'd been statements, there were notes, there were all kinds of things. So that being the case, we know we probably missed some of those, and still the number was pretty dramatic. And we've really worked hard over the last year to address that, and I am very happy to report we seem to have turned the curve on that. We have not experienced one of those deaths for several months. What I am, a little bit concerned about is January was a tough month, and we saw a little bit of an uptick. Our numbers are still very good, but that uptick is concerning, and it just reminds us of how much work there still is to do. One thing I want to mention, because I may have to leave just a little bit early, but as many of you know, and I know I see some of our original members, we have been doing this task force now for 14 years, and have kept it moving through COVID, through everything. So that, I think, is something to celebrate. And you will all be getting invitations, but I want people to make a note on April the 29th, Wednesday, April the 29th, from 9 to 11. We will be gathering up at UMass Lowell to celebrate the work that's been done, highlight the contributions of some of our folks, highlight the contributions of everybody, obviously, but some folks who've been with us from the beginning and the kind of work that they've done. Will just really take a deep dive into the progress we have made, really with the help of so many folks, many of whom are here. So just everybody's calendar fills up quickly. So if you just make a note of that, that would be wonderful. We are very lucky this morning to have Dr. Tracy Green and her colleague Krista Thomas Soas here with us to talk about local challenges and responses to the opioid crisis, as shared by people who have engaged in drug use across the Commonwealth. And we know that listening to people with lived experience has been an incredible asset. If many of you may know or remember, the way we started this task force was by inviting a group of folks who had lived experience to do a traveling around the county, talking about what their experience had been, what had been successful or not successful in helping them get to treatment and to recovery. What were things, one of the things we took a deep dive in were, what were some of the things that were going on in their life or that had happened that might have led them to some drug use early on? Because we really, if you think back, it seems amazing now, but 14 years ago, we really didn't know anything about opioids. And it was very different than the other drugs we had seen. So that mobile policy forum that we had for about a year and a half really helped to set the parameters of this task force. And it really was our view, just as it was very intentional to begin this task force in connection with the hospitals rather than at law enforcement or the courthouse. It was just as intentional to say, I don't really know a lot about this back then, and how can we learn about this? And how has that impacted things like our addressing childhood trauma and things like that, that we learned from those programs. So today's presentation is really a great opportunity for us to continue that learning. Dr. Green and Krista do some of the most innovative work in the substance use space here in Massachusetts. I'm really looking forward to this. And some of you may know, at the beginning of the month, the Substance Abuse and Mental Health Services Administration held their annual Prevention Day, which is the largest federally funded, federally hosted gathering dedicated to advancing the prevention of substance use, which is incredibly impressive. And really consistent with what we've been talking about. This year's event included an inaugural youth summit, which was a piece that we really want to highlight. We know and we see all the time young people bringing an important perspective to many, many issues. But I think including their voices and encouraging them to take action is particularly important around substance use, because we know it is often when people are young people that they begin substance use. And as usual, here in Middlesex County, we're a couple of steps ahead and have a number of ways for young people to engage and be addressing the issue. So we have Sarah Lincoln and Danielle McPeak with us from Cambridge to share their approaches. And I know that many of you do similar work. So it's so important to start this before it begins for people. And I think we're making a real difference in that. I was particularly heartened. I don't know if people saw it, and includes alcohol as well, that this year on Super Bowl Sunday, there was a 42% decline in the number of people actually drinking alcohol, which was shocking. And I have to say, we saw that sadly. For us, traditionally, the Monday after Super Bowl Sunday is usually an incredibly busy day, because a lot of people get arrested on that weekend for all kinds of things. I was pleasantly surprised not to see that on the Monday after the Super Bowl. And I thought, what is going on here? And then I read that article and I thought, well, I'm not saying that's a total correlation, but I'm thinking that all changed. And it wasn't that people, the article went on to say, we'll find that article and send it to people. It wasn't that people weren't partying. It was just that the partying didn't include alcohol. Lots of mocktails and other things that people were using. So let me go back to Sarah and Danielle. Sarah is the Youth Engagement Manager at the Cambridge Public Health Department, and she leads the efforts to create programs, policies, and practices to support young people, particularly in the areas of mental health and substance use. She's really committed to meaningful youth participation and believes that, as I think we all do, young people should be involved in every step of the process, from identifying the challenges to helping to create the solutions that impact their lives. She and her team work collaboratively to ensure that young people's voices are not only heard, but are really centered in public health decision making. And Danielle is the prevention and recovery specialist, again, for the Cambridge Public Health Department. And they received their MPH at the Boston University School of Public Health, studying community assessment, program design, implementation, and evaluation. And her work focuses on substance use in the adult population in Cambridge, including the data reporting around opioid overdoses, the harm reduction promotion, the overdose prevention training, and the management of the opioid abatement funds that have been awarded to the city. So I'm really happy to have both Sarah and Danielle here to share with us. Thank you.
Could
Oh,
I?
good. Okay.
Yeah. I'll just share my screen. Can everybody see this? Okay. I think so. Awesome. Great. Well, yeah, thank you for that introduction, and thank you so much for inviting us to speak to you all today. I'm Sarah. I'm from the Cambridge Public Health Department. I'm joined by my colleague Danielle. And really, we're here to talk to you today about the youth substance use prevention and mental health promotion work that we do, which we see more broadly as youth wellness in Cambridge. Much of this work is funded by the MassCall 3 grant from the Massachusetts Department of Public Health, the Bureau of Substance Addiction Services, and partially from the opioid abatement funds that Cambridge receives. So my team consists of myself, the Youth Engagement Manager, our Youth Wellness Coordinator, Connor Epstein-Krause, and 15 Youth Engagement Interns. These are all teens in Cambridge that work with us on a number of different projects. And then also Danielle is technically in another unit, our mental and behavioral health promotion unit. And I'll just turn it over to Danielle to maybe share just a little bit more about their work and how it connects back to this youth wellness work.
Thanks, Sarah. And thank you, Marianne, for the great introduction. Yeah, like Sarah said, I am a part of the mental and behavioral health promotion unit for the Cambridge Public Health Department. That consists of myself and my supervisor, and the two of us really focus on the needs of adults in Cambridge when it comes to mental and behavioral health. My work, particularly, like Marianne said, focuses predominantly on opioid overdose, both in like tracking and reporting data regarding that and where it's happening in our community, who it's happening to, as well as harm reduction services provision, including overdose prevention training for community members. And my supervisor and I work very closely with the city on the opioid abatement funds and how we want to spend that money in our community. But really value the work that I do with Sarah, and happy to be here today.
And so, when we have kind of thought about what we are trying to do in Cambridge, a lot of that was informed by our local youth risk behavior survey that's done every 2 years, and then also focus groups with young people, parents and caregivers, youth workers, finding that young people are using substances, at least in Cambridge, to cope with poor mental health. And oftentimes might also be doing it to fit in, which relates back to young people maybe not feeling a sense of connection or belonging in their community. On the flip side, we're seeing those protective factors of actually having positive relationships and participation in structured activities like sports or after school programs. I don't think any of this is new information, right? I think we all know these things. And that's where then our mission really is this, to ensure that all Cambridge youth have the skills, opportunities, and support to thrive by increasing youth participation in community decision-making and strengthening connections between youth and community resource providers. And so I'm going to be talking about these four main buckets of how we do this actually in Cambridge. Starting with, I think, maybe one of the most important pieces of youth engagement and representation, just knowing that it's really important for young people to be involved, like Marianne said, in all parts of the process, knowing that young people themselves are the experts in themselves. And at the end of the day, my team, our role is to help coach them in advocating and developing solutions. Pretty tangible thing that we do, which Danielle will speak more about, is our mental health and substance use education. We offer a lot of trainings to adults, especially caregivers and youth workers, just anyone who regularly interacts with young people, to help them recognize and respond to mental health and substance use challenges. And then finally, I'll talk about these last two things kind of in conjunction of just how we are better collaborating across different city, community, and youth organizations. And at the same time, what does it look like to really build systems that really work together on shared issues and advocate for the things that we need in our city. And really then what's kind of out of scope for our unit, I think sometimes people think we might offer individualized mental health or substance use treatment. That is a little bit outside of our scope, or that is outside of our scope. But that doesn't mean we aren't always in communication and collaboration with different treatment organizations. So oftentimes, we're always talking about the resources that are there and connecting people back to those resources directly. So the first thing I'll talk about is that youth engagement piece. I mentioned our team has 15 teenagers that work with us. We meet on a weekly basis. We started meeting for the first time in October, which was really exciting. And really, I have several things that I work on, but something that I've been really interested in having them do is really think about what projects do they want to work on that they see need to happen in Cambridge around youth wellness. So something that was kind of a mix of their interests and mine was, I mentioned our youth risk behavior survey that's done every 2 years in the city. And they created these boards, which are here on the slide. The top one is specifically about substance use, and the other two are about mental health. And they basically posted up in the lunch periods at the main public high school, and just we're trying to see the reactions of other students at the high school. So you'll see all these different emoji stickers, and the ones you can't read them because it's pretty small, but people also just directly wrote comments that they had about what they're seeing. It's also maybe a bit hard to see, but you see different trends over time. Some of the bar graphs are specific disaggregations by demographic groups. And so the more people saw that, the more they had to say about how surprising maybe sometimes it is to see, or not surprising, how different groups are being affected by mental health and substance use issues, right? I think it was actually kind of funny, and I find this to be true anytime I talk to any young people about the substance use trends, actually that they've been going down over the past several years, right? But every time any young person sees this data, they're like, this is not true. This is not true at all. And so just trying to continue that conversation of like, this is what our self-reported data tells us, but that doesn't seem to be true of your experience at school, in your community, that it feels like substance use is not going down. It feels like it's at least higher than what's reported. So when we hear those things, like I said, we want to continue that conversation, but then at the end of the day, what does that mean for us around youth substance use prevention? And so part of what they'll be working on and continue to be working on is just continued messaging around both mental health and substance use. You can scan this QR code if you want. It'll take you to a website that was created by a different group of young people called the Cambridge Youth Council, which I helped to make. But now formally, my teens have taken this on in really providing just the one stop shop for all resources in Cambridge and tips and things related to mental health and substance use. There's a page that's not directly linked on there, but relates back to this, what I was talking about, messaging around substance use, where it feels like the data doesn't match up with people's experience. And so continuing to explore that more in knowing at the end of the day, it seems like for the most part, young people aren't using different substances. And yeah, how do we rectify those two different experiences? And so they are continuing to work on this particular website, and will be launching a Youth Headspace 2.0, hopefully in the next month or so, and then starting to do a lot of different activities in their school and community to promote it further. I think with that, then I will pass it to Danielle to talk more about our mental health and substance use education.
Thanks, Sarah. So as she mentioned earlier, we are trained to deliver mental health education to community members using the Youth Mental Health First Aid curriculum. I'm sure most, if not all of you, are familiar with mental health first aid as a curriculum, but just in case, it teaches participants how to recognize the signs and symptoms of mental health or substance use challenges. And that is true of the general mental health first aid curricula, with the youth version being specifically focused on various signs and symptoms and how they might present in youth, as well as the specific challenges that may impact youth more than adults. So Sarah and I were trained to become instructors in June of 2023, and since then there has been sustained interest from the community in this program. We have formed a really strong partnership with our Agenda for Children out of school time programs. And we have set goals for ourselves to ensure that these programs have representation in our first aider cohorts. So about 60 participants from 23 unique out of school time organizations have been trained. Our goal for fiscal year 26 is to train at least one staff member from, oh yeah, sorry, Sarah. Yeah, if we could go back. I was saying that kind of was part of this slide. Sorry for the confusion. So yes, this is part of our goal to train at least one staff member from 80% of Cambridge-based out-of-school time programs. And we got some really great data from our fiscal year 2025 cohorts. So we collect some really great evaluation data, both as part of pre and post knowledge check surveys. And we do a 6-month follow-up as well. So a lot of the data I'll be talking about comes from those evaluation measures. So 100% of participants who responded to these surveys reported that they are more likely to engage youth in supportive conversations now that they've undergone this training. And 75% participants indicated moderate to high levels of knowledge for the pre-test, which then increased to 100% for the post-test, which we think is a really great sign that the training is working well. And then we have a quote from one of our participants that I think really highlights why we set our goals the way we do. So this says, I have not directly needed to support anyone. However, I have shared knowledge with my colleagues and had a conversation with my staff regarding Narcan and warning signs. All of the team know where the Narcan is located, both in the office and in the school, and that it is safe to use. So again, while our goal is to have at least one staff member trained from these different organizations, that is done with the, thinking in mind that they will then pass on what they've learned to other people in their organization. And I think this quote really highlights that is working well. And then on the next slide, we have some more highlights from our evaluation data. So a lot of this is from our fiscal year 2025. So, just to kind of give a little bit of more background, our previous goal was to have at least 40% of programs have at least one staff member trained. So we did meet that goal, which is why we put it up to that 80% that was on the last slide. I also really want to highlight that this training is really indirectly servicing a number of youth from marginalized identities across our community. So 85% of the trainees that we've worked with support multilingual youth, 81% work with LGBTQ plus youth, and 71% work with youth with disabilities. So, really bringing this training across, to many youth who may need it most. Some more post-training results that we've gotten from our data are below. So 90% of participants reported feeling prepared to act as a youth mental health first aider in these non-crisis or crisis situations. 98% found the training to be helpful and informative, which feels really good to hear as a person, one of the people delivering this training. And then up from 15% at pre-training, 71% participants felt confident asking youth about suicidal ideation. Again, for people maybe not familiar with the curriculum, one of the things that is taught is how to actually ask a young person, are you thinking about suicide? And really teaching participants like how to ask that, how to assess for suicidal ideation, and making sure that the first time they say those words isn't to a youth in crisis. So I think this really speaks to a lot of good work that Sarah is doing in the community. And I'm, like I said, very happy to be a part of it.
Thanks, Danielle. And so I'll close maybe before we can take a question or two, and just thinking about some of the city level systems change work that we are trying to do. We spoke a little bit more about direct youth and adult work that we're doing around youth mental health promotion and substance use prevention, but something that I began in this role almost 4 years ago was a youth wellness working group. And that was really meant to be a place to gather city and community partners to really think about how are we working together on all these issues. We're all maybe, especially after school organizations, don't call themselves or don't call the work that they do mental health promotion, but obviously what they're doing is so important to supporting young people, right? So how do we get together in the same room, having the shared language and vision? And so that's evolved into what it is now, and really thinking about how are we guiding that work more? And something that we've been exploring is this Child Friendly Cities initiative framework from UNICEF. It really just provides an umbrella for all the good work that's happening in our city. And so we are currently working on just like talking to more people about this particular framework. And actually the goal, I thought it was really important to connect back to the work that my unit does, right? So you'll see it's very similar to our mission, where we want to be a city where young people are heard, supported, by caring adults, and have what they need to thrive, no matter who they are or where they live. And ultimately, again, it's like I said, so many people are doing such great work in Cambridge. There's so many resources. If anything, this gives us just a better way to connect the dots and really align our efforts under a shared vision, so that we ultimately are just improving outcomes for our young people. And so this is something that's a lot more new and in the works, but already people are just, I'm seeing, are very excited just to continue working and really think about how we are improving wellness for our young people. But with that, thank you so much for having us. I've put our emails here if you're interested in reaching out and learning more. I'm not sure how long we've been going, Emily, but I don't know if there's some time for questions. We can do that, but I'll stop sharing.
Thank you. Thank you both. Questions, comments?
I have a couple questions and they're related. So Danielle, can you definitely touched on this, but could you be a little more specific and give a few examples of when you're trained to work specifically supporting the youth, what kind of things are the folks trained to do is my first question. And then the second question is, and when you talk about those percentages of folks who are qualified or trained to work with the youth, those are in different organizations throughout Cambridge. Does that in any way touch on the schools at all?
I'll take the first question and I can attempt on the second one. I think Sarah can speak more to the school connection between OST than I can. But yes, so the mental health first aid curriculum is really geared towards, again, teaching people to recognize the signs and symptoms of mental health challenges. So as part of the curriculum, initially participants learn more about what the common mental health challenges are faced by young people, and kind of get some data around like prevalence among youth. And then we move into, there's a action plan that is taught as part of the curriculum, where it goes into, I won't go into all the nitty gritty details, but it really focuses on like, how do you assess for a mental health challenge that may be happening? How do you assess for potential suicidality? How do you approach the young person? How do you offer them support in the moment, whether it's connecting them with appropriate professional help or encouraging them to engage in activities that may like make them feel better, such as like self-care activities. And it's an action plan that's non-linear, and it's not designed to be used in every single case, but it's a toolkit that participants can then apply in given situations. And then we talk about how that action plan can be applied to various types of mental health challenges, including non-crisis situations where there might not be immediate help needed, versus like all the way to what would be considered a crisis situation, and preparing participants to do things like calling 911 or administering Narcan, or whatever the case may be, kind of how to respond to these different situations. And a very key part of the program is like, we're not teaching people to diagnose anything. We're not saying like, oh, you can go up to a young person and be like, I think you're depressed. But it's about, recognizing how things might, behaviors, thoughts, feelings, and emotions might change for young people, and how to respond effectively. And for the second part of your question, yeah, actually, I'll let Sarah, you take a stab at that second question, if you don't mind.
Yeah, so I think our current goal was to focus more on out of school time organizations, because it is a lot easier to schedule for their professional development purposes. It's a lot harder at the school level. since they have very specific PD days. But actually last year, someone else from the security team at the high school and the middle schools approached a different trainer, and that trainer had reached out to me to actually co-instruct. So we actually trained all the security staff in this at the middle and high school. But this is something that we want to do more of, more school staff, teachers as well. So that's something that we're constantly talking about with them. But for now, when we first got started, only a couple of years ago with this, it was easier to start with youth workers. And then oftentimes a lot of these OST organizations have connections back to many of our middle schools and high schools. So still working on that.
That's great. No, thank you. Very informative.
Anybody else? Thank you both. That was great. Thank you. Good work in Cambridge. Thank you.
Thanks for having us.
And we're going to turn now to Krista and Dr. Green. Krista comes to this with a background in frontline harm reduction. She was doing that in Woonsocket, Rhode Island. In 2018, she was hired as a community liaison to work very closely with the community to establish a successful street outreach program and a peer-run drop-in center. Now she is a program manager supporting community engagement, harm reduction, and drug checking work being done by Dr. Green's team at the Opioid Policy Research Collaborative. And Krista holds a bachelor's degree from Johnson & Wales. And Dr. Tracy Green is an epidemiologist, welcome, whose research focuses on drug use, opioid addiction, and innovative interventions to reduce drug-related injury. She is a professor and the director of the Opioid Policy Research Collaborative at the Heller School for Social Policy Research, Policy and Management at Brandeis. And she's also an adjunct professor at Brown University, where she co-directs the Center for Biomedical Research Excellence on Opioids and Overdose at Rhode Island Hospital. She presently oversees the community drug checking resource, and that we'll have a link for that for families, patients, and community organization seeking support either with naloxone and the continuing education course designed for pharmacists and technicians on prescribed and over-the-counter naloxone, syringe access, and harm reduction supplies. So I'm happy to have you here, both here to share the results of your Exploring Community Knowledge study. So thank you.
Thank you so much, Marian, for the invitation and to be able to have some time with you all this morning. Forgot to mention that I'm a proud Middlesex resident too. I'm waving to you all from Wayland. And I'm really glad that my daughter, who's in the high school, is also really involved in the medical club to access naloxone on their campus and in the community. So those are all today feels very, very, very much like I'm amongst family and friends.
All better to have Middlesex people.
Totally. So today, Krista and I were going to share with you all some of the regional findings from our EXO project. We piloted this last year in 2025 and are about to embark on the full-fledged version in 2026, which just means 100% sample rather than the 50% sample. But we call this EXO, a little snail as a logo to remind us to sort of slow down and take some time to share about how to stay safe and how people are experiencing their health. Go ahead. Next slide. We have a big team. And so you'll have met, well, me and Krista today. And there are others though here from Brandeis and other institutions. And then also on the next slide is introduction to new addition that we brought on last year, which were community researchers. You may know some of those individuals. They represent people all around different regions of the state that are working more or less full-time in other community organizations or hospital settings, and providing services directly to people who use drugs. The idea was to embed and engage with the community in a more active fashion. So these community researchers became part of the Brandeis team, and we trained and had the opportunity to work with them for data collection throughout. So that is our team. And just as a reference point, the reason why we felt really compelled to take this statewide is because we had done 19 prior what we called rapid assessments of consumer knowledge all around the state. From pretty much the time that fentanyl was seen, we recognized that we didn't know a lot about fentanyl. And I appreciate, Marion, your point that like we really didn't know about opioids very much. Overdose itself, Chris, that what preceded and what followed, what worked for people connecting and reconnecting to care, all of this, and especially how quickly we needed to adapt with fentanyl, were part of the reason we did these rapid assessments all around the state. And we did that in partnership with our communities, and that really helped to shape new policies and different services, identify those other services and supports, especially in harm reduction, that were most needed, and to think about those gaps that were different, especially regionally and demographically, that we wanted to pay more attention to. And we did that by focusing and partnering with people who use drugs, and to lift up the survey and interview data directly to the Department of Public Health. So these are CDC and Commonwealth of Massachusetts funded efforts. And the next slide is to tell you a little bit more.
Yeah, so I'll talk a little bit about the methods. Like Tracy said, we were building on the foundation that was created with the prior RAC studies, highlighting the importance of that collaboration with community members and people who use drugs. I think it's really important to understand that those relationships are what makes this research possible. So we're so grateful to all of you who have let us into your spaces and connected us with folks, and we're excited to kind of continue that in the future. We collect information about folks who use drugs from surveys, participant interviews with community partners, as well as collaboration with community researchers. So again, making relationships with those trusted folks who already know the folks in the community who are using drugs, so that we can get the connections to those people. Survey and interview topics in EXO include substance use, how drugs are consumed, overdose experience and response, medications for opioid use disorder and other treatment, as well as the local drug supply. Our annual timeline, we generally spend the winter kind of December to February goal setting and planning. We meet with DPH to set goals and discuss kind of what we're trying to glean from the survey. We host the Community Researcher Academy, which is actually, I think, maybe wrapping up today, which is really exciting. So all of those kind of key people in community that we're relying on to help us with this research are going through that training now. March to June, we work on recruitment and data collection, plan regionally, and start to actively collect data through surveys and interviews. July through October, we work on analyses and planning for community shareback sessions and presentations. And then November to January or February, like today, sharing results back. We had in November an overdose research summit hosted by DPH, as well as a number of other community sharebacks. Survey sampling and recruitment. This is just to give you all an idea of the data we're talking about today, kind of how it was collected, where it was collected. This coming year, we have a goal of 500 surveys. January to March of 2025, we piloted with 250 surveys. So this is about half of the data we'll hope to be working with in the future. And these are the regions that we have been working with. So it's broken into 5 regions with about 50 surveys in each. Back to Tracy for results.
So we're going to share a little bit about the surveys and the interviews today. And I realize we have a lot of information. And in fact, if there are things that you're particularly interested, please do feel free to reach out to us, and we'd be happy to either prepare some data that we can share in specific, and then we will have some one-pagers or back and front and back, so it's maybe 2 pages, but that overview the results. Just as a reminder, I think maybe the next slide. We did talk with people when we think about Middlesex for those regions, the medical and coordination regions that you saw. Middlesex County spans 2 of them. So we have some complexity today. Depending on where you live, feel free to reach out or look at the Northeast or the Greater Boston Metro West, the GBMW results. But we're trying to actually present both as much as possible. There's, of course, similarities, not just around the geography, but also in the demography. And but here depicted are kind of the big question of who do we speak with, and these are depicted just for the Northeast, but the participants in each region numbered about 50. And in Middlesex, that meant that we had slightly more men. A third had been an experience of Section 35, some important racial and ethnic representation. And there was a sense that in the Northeast that more of the respondents were older. And then finally, we have important representation of unhoused individuals. And you can see in the bottom right-hand corner the other communities that are represented in the data for Greater Boston Metro West, including, I know Cambridge just presented, so the findings if you find your towns maybe closest to, and then subsequent slides, you can maybe think about which kind of fits a little bit more of and may be more meaningful to you. In general, in Greater Boston Metro West, there were more women. The demographic was younger and more diverse, with more Section 35 prior experience. The next slide tells us a little bit about the substance use. So again, across the state, we did see that cocaine and crack were the dominant drugs that were used. Fentanyl in about just over half of the individuals that we spoke with. And then heroin, and this was heroin. This actually is both what people think of heroin, as well as from our drug checking data, we are seeing a rise in heroin. But to this point, because not everybody uses drug checking, we may be thinking more of like heroin, dope, and fentanyl as much the same thing in a self-report environment. And methamphetamine and alcohol use were also important to think about and see. In the communities of the Northeast, in compared to the Greater Boston Metro West areas, we did see more fentanyl in the Northeast area. The next slide. So when we look and bring that out to the snapshot of the regions, while there weren't really differences in some of the stimulant use and the alcohol and tobacco cannabis use, there were important differences on the illicit opioid front. And so bringing your eye to the right-hand side where Middlesex County stands, we do see a high rate of fentanyl use, as was mentioned in the prior slide. And the way that people were using, where snorting fentanyl and heroin was something that we heard from people who are using these drugs, and use by injection in the Greater Boston Metro West areas. And so thinking about access to services and supplies to stay safe is a theme that will continue to follow in the next couple slides. Next one. So diving into the drug supply. So a dominant aspect of what we heard from our surveys and interviews is that we have a very as you all know, a toxic and unregulated drug supply, but one that has been shifting quite dramatically. And in these, in the year that we've followed people and heard from them, they shared that these shifts are really having an effect on the way they use and how they use, in complicating or impairing entirely their access to and use of medications for opioid use disorder. And also a changing aspect of their overdose response, whether that was how they would use naloxone or the idea of using naloxone, when to use naloxone. And so there are some quotes from individuals that we spoke with that kind of capture some of these particular trends. And in the first instance, where we really see the individual sharing that recognizing that the supply is different, it's not good, and they're having to use in different ways, and recognizing that injection may be they're having to inject many times, or making them not want to use as much anymore. The second person really reminds us that xylazine was making their access to and use of methadone more challenging, that it didn't feel like it was working for them, and second guessing whether they should even be on it with the challenges in the drug supply with the xylazine. Xylazine withdrawal does present differently from fentanyl withdrawal, and this was an indication that the treatment systems maybe need to also understand that what the care looks like like we need to change and adapt as well. And then the third quote is a reminder that people experiencing an overdose, for instance, that does have xylazine in it, that they have the perception that Narcan's not working or naloxone's not working. This is an indication that the person really recognizes that xylazine isn't responding, it does not respond to an opioid antagonist like naloxone, because it's not an opioid, but they're very sedated. And so this question of how do we respond to overdoses that are where heavy sedation is occurring was really what we were seeing in these drug supply shifts. The next slide focuses a little bit more on what we heard in the Northeast in particular. And so with the Northeast being characterized by highly unstable and adulterated drugs, people really reflected that their use was unpleasant. They didn't have an effective high, that it was unenjoyable, uncomfortable, and not numbing anymore. These were identified as positive aspects of what people were looking for, and that wasn't what they were experiencing. But other things that were happening in the drug market and experiences that people had with respect to their use and the supply was recognizing that encampment sweeps and anti-camping enforcements that were happening were more frequent and punitive, and this had an effect on the drug supply. The key informant interview at the bottom provides some insight into what they were seeing and its effect on the drug supply. This individual said that law enforcement would cyclically will just start cracking down, which creates a whole bunch of problems. First of all, it's literally a situation that they condone and help create, but then they crack down on them. They have to move everybody on. And then when people aren't using in the spaces together, that's when people move and spread out. And that's when you start finding bodies in people's frigging basements and stuff. So this was a reminder that some of our actions actually can have a local effect on the supply. And while we heard from people that they were aware that their drugs were contaminated, they still, to avoid withdrawal, had to feel like they still needed to keep using despite these safety concerns. And then finally, the reaction to some of these supply effects were to change their routes of administration. And in particular, in the Northeast, we heard this linked to xylazine-related wounds and vein damage from injection. The next slide. Okay, so talking about the way that people are using. So the statewide, this change in route of administration from was also occurring in traditional ways where we would, I guess, in people who study drug use, we recognize that people move from oral and smoking or snorting often to injection for many reasons. But this pattern, instead, what we were observing was what we termed reverse transition, where people who were injecting drugs were shifting to sniffing or smoking. And this really was linked mostly to health risks and outcomes. So either not feeling like they were having to inject many times and worrying about their veins, or in this case, from this quote from Hispanic men in Western Massachusetts, who reflected that the sores and abscesses that he was experiencing and really were part of why moving to injection wasn't working or wasn't what he was wanting to continue to do. And so this reverse transition is something that is not a fairly uncommon activity, but the fact that we heard it so frequently was a reminder that people who are sniffing and smoking drugs may be coming into our services and need supports as well. And the next line was really what we heard that the state has been hearing, that people are seeking these supplies and services because they may be continuing to go to harm reduction organizations and other health organizations that provide access to sterile syringes. They also are starting to understand and can seek and see their access as important for safer smoking and snorting supplies. So by region, Greater Boston and Metro West, as well as the Northeast, really had exceptional access in harm reduction programs to safer snorting and smoking supplies. And that was in contrast to other places where people might be obtaining supplies like from a smoke shop or a vape shop or a bodega or a gas station. even a pharmacy, these are locations that have less opportunity to provide education and a touch point to a healthcare provider or a trusted professional who could provide additional sources of support, linkage to care, and referral to other recovery and harm reduction services and medical connection. So the fact that this region really has quite a lot of that occurring is kudos to you all for building this out. And those important transitions away from injection and to these other routes of administration that are less associated with things like infectious diseases and abscess. And these are important health-oriented population level shifts to be aware of and thinking about.
All right, I'm going to take it back over to talk a little bit about overdose experience and response. So we have statewide, the number is basically almost 60% of folks who were interviewed reported carrying naloxone with them. So another 10% said that they usually carry it but needed a refill. If folks don't carry naloxone, about 44% said that they keep it where they use. So even if they're not physically carrying it on them, when they have a location where they go and use drugs, they have naloxone there with them. And statewide, about 16% of people who responded said that they didn't keep or carry naloxone with them where they use drugs. And I think that's about 41 of 256 people. So it's not a huge number of people, but there's still room to make sure that people know. I know when I was doing direct service work, people would be like, well, if that's not my substance of choice, then I don't need to carry naloxone. But just continuing to provide that education, letting people know, that they can carry it for a friend if they need to, whatever the thing is, to make sure people understand that they have access to it. Across the state, definitely a highlight in the Northeast and the greater Boston Metro West areas. Harm reduction programs are definitely the kind of #1 place that people are accessing naloxone. So again, like Tracy said, big snaps. Congratulations to the orgs that are making sure people have naloxone kits, because we know how important that is in combating the drug toxicity crisis that we're navigating. Interestingly, also in Northeast region, about 12% of people were getting their naloxone from an MOUD clinic. So an OTP, or where they're getting Suboxone, stuff like that. It is, really great to see that people are not only accessing their treatment there. Oh, I'm not sure why someone's drawing my screen here. Shelter and housing programs were also 12.2% in the Northeast and 7% in greater Boston Metro West for that. Statewide training needs and education boosts. Most people have received training in naloxone, 74%, and rescue breathing, 72%. Definitely an area for kind of growth in the Northeast. Only about half of the people surveyed had been trained in rescue breathing, which, especially with the other sedatives that are kind of infiltrating the drug supply right now, really, really important to make sure that not only do they have naloxone and know that they should still use it, but also to encourage people to be trained on and understand rescue breathing. So that's definitely an area of focus for the Northeast. Fewer people report having been trained on the Good Samaritan law. These are statewide numbers. About 60% and about half of the people surveyed said that they had been trained on fentanyl test strips. Again, we understand that those are take a little bit of time to get people trained on, but we also want to make sure people understand, that they're protected when they call for support, and that they have the access and knowledge to test their drugs accurately, whether it's with test strips or by connecting with a community drug checking organization. Some folks that were interviewed were newer to harm reduction and drug use, so 9% statewide and about 14% in the Northeast had not been trained on any kind of overdose prevention. But again, those are small numbers, but there's still opportunity for growth and improvement there, and just letting people know these resources. And just as a note, Greater Boston and Metro West training history was comparable to state levels. Back to Tracy.
So one question we were curious about was really understanding about people's use behaviors in different scenarios, and in particular, what was their usual scenario? Was it a monitored or unmonitored scenario? And in truth, there is the never use alone idea. And so using completely alone was not the most common thing, but we had a number of people who were using in unmonitored fashions. And in fact, almost half reported mostly using in scenarios that were unmonitored. Why is this important? Because we have tools like SafeSpot, and of course, opportunities to connect with peers and family members and others to just let someone know, have a tough conversation, but an opportunity to discuss about checking in, and SafeSpot, if you're not familiar with the virtual spotting hotline, where you can call anonymously and have a peer with you on the phone when the use is occurring, and calling 911 and response if something were to happen. So there's here an opportunity, whether it was the half of individuals who were using in an unmonitored environment regularly, or the 3/4 who said it's happened at least once in the past month. So unmonitored use is very much something we'll be watching into the future, and thinking about strategically at the region level would be important to think about for interventions and other supports. Next slide. So just to now shift gears to medications for opioid use disorder and some other responses. So we were curious about people's touch points for medication treatment, and asking people, and most people had actually had a experience using medications for opioid use disorder in their lifetime. That was quite high in the Northeast and the greater Boston Metro West area. What kind of medication that was typically methadone. It was about the same, about just over 50% in both regions. And buprenorphine was less used endorsed in the Northeast in terms of past year use of that medication, and about a third in the greater Boston Metro West area had indicated this. So following along here on this table, you can kind of see that the type of medication treatment we asked. So if you use these medications the past year, where did you receive them? And so in the bright yellow sections, you can see that the vast majority of individuals, and this is statewide, because there weren't too many differences regionally, but here the OTPs, the opioid treatment programs, methadone clinics, were the primary touch point for accessing and using methadone, buprenorphine, and naltrexone, as well as Sublocade. So that's injectable buprenorphine, as well as doctors' offices for buprenorphine, as we'd expect, and for injectable buprenorphine. But if you move your eye over to the criminal justice and Section 35 facilities, this is where, and of course, this is the year, so people may be coming in and out of various spaces. But considering that over a third had criminal justice history within the past year, this is problematic, to say the least. That methadone, buprenorphine, and even it was helpful to see injectable buprenorphine on here as options, but there were very few touch points within the criminal justice setting that involved medication treatment. It's another place we can continue to improve. Next slide. For you.
All right. I know we're getting close to time, so I promise I will talk fast for everybody. Novel harm reduction services, knowledge and access. So like Tracy said, novel harm reduction services, things like SafeSpot, things like hotlines that folks who are using drugs can call, harm reduction vending machines, drug checking services. These are all initiatives that we feel like are really valuable, and depending on the community's needs can really benefit folks. Notably in the Northeast, over 50% of people said they had seen or were aware of naloxone boxes. So that's really cool and exciting that people know what they are and what it is and how to use it. Over 50% of people in the greater Boston Metro West area use drug checking services. We do have a quote up here talking about the impact that harm reduction orgs and what they're teaching us about the drug supply, how to be safe, how influential and impactful that can be. We also have a graph down at the bottom right where it talks about when people use drug checking services, what do they do about that? Do they, talk to their friends about the results, which is very common, change the route of administration, basically, use the drugs in a way that is different given the information that they now have about them. So all of that, again, really impactful, really useful things for folks, and just, highlighting the knowledge that people have already about them and the areas where we can continue to provide education to let people know these things exist. supplies and services that need greater attention. Like we just said, many were aware in the Northeast of, drug checking services. The current use of drug checking services was about a quarter of people. Only about 6% of respondents reported any difficulty accessing them. So maybe people just are, connected in the Northeast to a reliable drug checking place. But we can definitely continue to, talk more about that with people and let them know where the services can be found. In the Northeast, we know that syringe disposal is definitely a hot conversation in a lot of communities. But folks statewide, few found syringe access difficult or extremely difficult. Almost twice as many found it difficult or extremely difficult. Disposal ease in the Northeast, which is a huge win. 90% of Northeastern respondents who inject drugs reported disposing of syringes as easy, and were able to get their used syringes to harm reduction spaces to make sure that they were disposed of properly. In the greater Boston Metro West area, about a little over 20% of people responded reporting difficulties with syringe disposal. So we can all, work to make sure that people have safe places to dispose of their used syringes. And continue that in all of our communities. Harm reduction programs were still the main location for syringe access. 90% of people and safe disposal. 95% of the Northeastern respondents said that they were disposing of them properly, which is great. We do want to highlight across Massachusetts, BIPOC residents compared to non-BIPOC respondents consistently rated greater difficulty in accessing safer use supplies, syringe smoking and snorting, and test strips and wound kits, but not condoms, naloxone, or drug checking services. So from a racial equity perspective, it's really important to understand that we need to be reaching all of these communities, and that we still have room to grow there. Handing it off to Tracy for key findings, and then we'll be done. Thanks so much for your patience. Go ahead.
Yeah. So bringing it all together, the changes in the drug supply really reflect changes in how people are starting to use their drugs, how they're experiencing and navigating treatment, and how they're responding to overdoses. And there are new challenges. We may need more wound care. We may need updated trainings on naloxone and overdose response, and to fill some gaps that you saw in the data. There's absolutely interest in expanding medication treatment and room to grow for opioid use disorder treatment in places like jails and prisons and civil commitment programs. There in the greater Boston Metro West region, we saw quite complex and regionally tailored overdose responses, including things like nalox boxes, which was exciting. And then thinking about the access to and provision of harm reduction services was quite active, and a lot of the supplies were meeting the needs of the people in the community. But there were important regional differences, and between racial equity and considerations around access to disposal, for instance, and fundamental drug checking services. There's some room to be synergistic and to lift that opportunity to impact harm reduction services for the positive. So those are our overall state and some regional findings. It was a lot of data and to take in. We'd be happy to answer any questions or if you have any comments, and we'll stick around as well as provide some of those handouts for you too.
That was excellent, Krista and Dr. Green. Thank you so much. I was particularly impressed with how well you read my mind, because when we were talking about the testing strips, I started to wonder, so what happens after they use those strips? And then you went right into sort of the drug checking methods and what folks do. So thank you, because that was incredibly informative. So does anyone else have any other questions? Yes, Karen.
Yes, thank you. I didn't know if you saw my hand. That was very informative. And, we have a task force that goes out and meets with unhoused populations, and you have me thinking about all kinds of things. First of all, could this presentation be shared with us? So I might share it with some of those frontline responders and they can see that. And then
Yes.
The second question was the intramuscular naloxone. That's new information to me, and I'm wondering about our EMS and if they have it. So is an intramuscular injection of naloxone, does it work more quickly than the nasal spray? Is that the goal of it?
Yeah, it's almost it absolutely works just as well. It is an opportunity to titrate naloxone, so smaller doses could be provided. Why is this important? Because in the age of other things added to the drug supply, there still might be respiratory depression that's associated with the fentanyl or other opioid, but there are other things that are on board that are making the sedation really hard to, so people aren't responsive, but they are breathing. So giving them a ton of naloxone again and again and again could risk precipitated withdrawal. And because they feel terrible after, you know, all the withdrawal that potentially is, would require hospitalization, how bad it is. To bring that all back really quickly with so much naloxone is a concern. So some communities have embraced intramuscular naloxone. It's accessible. It's on the clearinghouse in terms of programs have access to intramuscular. So if that's something that your community is interested in, we'd be happy to connect you through BSAS to that. And EMS usually do have access to injectable naloxone too.
Thank you. Thank you so, so much.
Yeah.
Do we have any other questions? Do any members have any updates that you want to share with us? Well, thank you everyone for joining us. Thank you so much to our presenters, and to everybody else. Just remember that you can reach out for Narcan or testing strips. We always have those available. Thank you so much, and see you next month.
Everyone. Take care.
Bye.